Good afternoon. Welcome, and thank you for joining us today for the Black Health Trust Weekly Program. We're so pleased that you've chosen to empower yourselves today by joining us. It's great to have all of our regular attendees back and those new to the program. My name is Michelle, and I'm your hostess for today. I hope you're all doing really well from wherever you're joining us. Today, our panel will be moderated by the distinguished Dr. Randall Maxey, Chief Medical Officer of Advanced Community Medical Care Corporation in Los Angeles, and also President and Founder of Black Health Trust. He will introduce his wonderful co-moderator and guest speakers for today. Before I read BHT's mission statement, I'd like to acknowledge a significant event and beginning of a new era in American government this week with the inauguration of the 46th President of the US, Joseph Biden, and the very first US female Vice President, Kamala Harris, last week. This is an historic event worthy of our mention and respect, particularly since VP Harris is a woman of color and who has broken through yet another glass ceiling. Let's continue to stay informed about policies and show up at the polls whenever there's an opportunity to vote. So the mission of BHT, Black Health Trust, was founded in response to the global pandemic and Dr. Maxey's desire to keep his own family safe. And lucky for us, his commitment evolved into a vision much larger than expected. The purpose of the mission is to provide credible insights from our community health experts to best serve our colors and communities of colors with a coalition of leading and longstanding Black medical professionals across a diverse spectrum of disciplines to offer unvarnished opinions and insights into our physical and mental health during these challenging times. These opinions are offered to help educate and inspire you to take your health seriously and to ask questions of your own medical practitioners. I'll share a few housekeeping items as usual. The video conference is live. It's a live program and it is being recorded on different public platforms like Facebook Live and YouTube. Your participation on this program is completely voluntary, and if you choose to stay on the call and prefer not to have your image and likeness displayed, there are visual and audio settings on your personal device that you can control to block your picture and mute your voice. That said, all participants will be muted by our Zoom technician initially, and we ask that you remain muted until the host or moderator asks you to contribute in order to minimize the distraction of background noise so we can give 100% attention to our speakers. So just double check and make sure that your device is muted. With regards to the chat room, we'd love to have your questions and statements. If you have any questions, you can enter them into the chat box. Just please limit your questions to 2 questions per topic being addressed, and please do not use the forum to advertise or promote your personal products. We have a limited amount of time, so we'll get to as many questions as we can. Our disclaimer, and you'll also note the disclaimer in the chat box. Please note that the information communicated on this program is not intended or deemed to be medical or legal advice, and you should always consult your own medical or legal professional for advice and direction pertaining to your particular needs and situation. The information presented here is not advice, but rather opinions and recommendations from credible sources. Black Health Trust, its representatives, members, employees, attendees, heirs, assigns, and guest speakers and presenters assume no liability whatsoever in connection with your use of the information presented or used by anyone, nor are these discussions directed to specific situations. Again, we strongly encourage all attendees of this program to consult your own legal or medical professional for conclusive guidance on how to proceed in your own personal circumstances. So we are in this together. If this program has been valuable to you and interesting to you, please visit the website to learn more about our programming and how you can support Black Health Trust so we can continue bringing our community outstanding program. Visit www.blackhealthtrust.org. That's blackhealthtrust.org. So we want to thank the Black Health Trust Committee, all of our committees, the steering committee, the executive board, and the virtual administrative assistant, our production and Zoom technician, our BHT supporters, and all of the people behind the scenes for their time and efforts that make this program possible. Let's now welcome all of our distinguished physicians and special guests. We thank you so much for sharing your valuable time, your information, educated insights with us today. Your participation and support help us to empower our communities of color, and this is critical to our present and future well-being as a people. Knowledge is power. Welcome again, everyone. Thank you for joining the Black Health Trust Weekly Program. This is our community and our time to improve our health. Dr. Maxey, would you please do us the honor of presenting and starting the program?
Thank you very much, Michelle. I appreciate you so much being our hostess for all of this time. And we just want to say our thanks to you.
Thank you.
Welcome, Dr. Barbara Neighbor Stevens, my partner and associate in moderation of this program. We thank you for bringing the wisdom of the South. They tell me that people are extremely wise down in Tennessee. Is that true?
Absolutely.
Okay. And I want to welcome, and I know you'll introduce them later, we've added another co-moderator to our group, is Dr. Ivan Walks, a longtime friend from the city of Washington, D.C. and nearby. Welcome, Dr. Walks.
Thank you. It's an honor to be with you all.
No, very good. Dr. Barbara Neighbor, and I'm just going to do this a little bit flying by the seat of my pants. Dr. Barbara Neighbor is a physician that I've known for a long time. She has an MBA. She's a fellow of the American Academy of Pediatrics. She completed her pediatric residency and then served for 2 years in the National Health Service Corps. She served as an assistant medical director for the Tennessee Bureau of Medicaid. She's been the director of pediatric education at Meharry Medical College. She later entered private practice of pediatrics, and she was smart enough to get out of that. And she served in leadership roles at several managed care companies across the country. Dr. Neighbor Stevens has served as chair of the National Medical Association Pediatric Section, and she was a member of the NMA Board of Trustees, and she is currently the chair of the Council on Medical Legislation. She resides in Tampa, Florida. She's married and she's the mother of 4 children. We welcome her and thank her so much for helping me as we have grown this program. I want to go to the first information slide and then I'll ask her to comment. The first slide starts with the total cases back in November of 2020. And we were quite alarmed that the total cases on that Sunday were 11,843,493. And there were 93,811 new cases, and we were shocked. And the total deaths were 253,600. And then we come to today, January 24th, 2021, where the total cases today are 24,704,000. The average daily cases per 100,000 in the last 7 days is 54.4, with the total deaths at this point of 412,592, with there being in the last 24 hours, 3,895 new deaths that have occurred. I'm very concerned, as usual, that the people that are having some almost 3 times the rate of death than the other population are people of color, specifically African Americans. So this is why we come on every week to try to bring the most credible information from the most well-informed, well-respected physicians in the country, most of whom are physicians of color. And we want you to know that within our group of people, our Black medical schools, our Black communities, that we have physicians who are at the top of their game and the top of the medical profession, and they're well respected and well prepared. Now, we also live in the United States, and there are other physicians who are also very good, and we've sought to include other physicians with us as well, and they've been very committed to taking care of not only all patients, but especially paid attention to communities of color. And we welcome all of them. Many of them have joined our medical advisory committee, and they serve with us and keep us informed. Now, I do believe as a result of what we had select round table some months ago with not only physicians, scientists, we also had members of certain national security agencies, et cetera, with us. And we did discuss, is some of this pandemic willful? And is the fact that the United States has fared so poorly when compared with the rest of the world in providing appropriate care, vaccines to communities of color, is it willful? And we did determine that it is willful. The nation of Israel, which only has 9 million people, has a 34+% percentage of people receiving the vaccine. The people in Taiwan have received necessary treatment. They have very few deaths that have occurred. All these small countries with nowhere near the financial bandwidth that we have here have done better than us. So we want to make sure we get the message out. And as the program goes on, you'll see what we're saying. I do believe that in many cases there is a conspiracy to prevent communities of color from wanting to take the vaccine. So we want to provide as much light on the subject as possible, and we'll call on some of our experts to speak to that. But of course, everybody has to follow their own mind, their own physician's advice, and we're not trying to twist anybody's tail, but we are trying to illuminate and show you the facts. Dr. Neighbor, welcome to the program. I'm so glad that you are my co-moderator and as well as friend, and we also welcome Dr. Walks. Dr. Barbara Neighbor, would you go with us and start in our program?
Thank you so much, Dr. Maxey, and to our audience, welcome and thank you for joining us. I want to underscore the remarks of Dr. Maxey and share and punctuate his remarks with the thought that we can't back off of the public health measures that we preach on every week. Wear your mask, wash your hands, and socially distance. But I'd like to kind of dress it up a little bit because, you never know how things are going to play out. I have a daughter and her family that live in Bern, Switzerland. And so we have been comparing how things have been going between Switzerland and the US the whole time of the pandemic. She happened to mention to me that the Swiss government is contemplating enforcing not just wearing a mask, which is already in force, but specifying a particular type of mask with enhanced barrier protection. Coincidental with that conversation, I heard the same day that the CDC is now advising that you not just wear one mask, but that you should seriously consider wearing 2 to 3 masks to increase the barrier protection that the mask can provide to prevent those droplets that Dr. Despani told us about last week from spreading. I'm bringing this up because if you read between the lines, it is not difficult to see that there is a concern about the spread. There is concern about the infectiveness. That means how effective it is in infecting you. And I think we should pay attention to the warnings that we need to double up on our efforts in wearing our mask. If we want to pursue that further later in the program, we certainly will have the people on our panel to address those issues. We are really thrilled today to have a outstanding panel as usual. Our first speaker will be Dr. Carol Archie, who is an obstetrician gynecologist living in Los Angeles. Our next speaker presentation will be given by Dr. Keith Norris, who is in California as well, and is a recognized clinical scientist and nephrologist. And our third speaker, and who was also the producer of this week's program, is Dr. Jordan Despani, our well-known virologist. We have a couple of surprises to sprinkle in along the way. And with that, I'll turn it back over to Dr. Maxey.
Very good. What I'd like to do quickly as we start is introduce our new associate, Dr. Ivan Walks. And I'd like him just to have a few introductory words, and I think he wants to look at a couple of slides, and then we'll go to our first speaker.
Thank you very much, Dr. Maxey, and good afternoon, everyone. It's always good to be with you to see. So especially pointing you out, Dr. Maxey, those who are young, gifted, and Black. So I put you at the top of that list. I would also like to focus on the pandemic for just a moment. It is, it's really a big deal. It really is a big deal. And I want us to just understand the seriousness of that. I was talking a couple of weeks ago with the Reverend Jesse Jackson, and he has a way of saying things that just get to the point. To quote Reverend Jackson, he said, "We are the sickest and we are dying the quickest." And I told him I was going to steal that and say it every chance I got, because it really gets to the heart of the matter, doesn't it? We are the sickest and we are dying the quickest. Every time we touch our community, we are touching health disparities. And this is no exception. We do have those existing disparities. And to that point, we need to be able to speak to our community about the vaccine. That is our best intervention that we have at this moment. The first slide that, if we can put that one up, it looks at who we trust as a community. There was some research done by the African American Research Collaborative, and the slide shows that there is a role for those of us on this call. When you look at who folks are trusting, they're trusting doctors and nurses. They're trusting the health professionals. They're trusting the people that Dr. Maxey and Dr. Nabert Stevens have pulled together on this call. And so we have to make sure that we are giving good information. Other folks that we think everybody trusts, Black elected officials, Dr. Fauci, sure, they're on the list and they're up near the top of the list, but they're not up where the doctors and nurses are. So we have an opportunity and an obligation, I believe, to make sure we get the word out. And when people ask us what should they do, we should be able to confidently say that we are supporting them, talking with their local doctors, but at the end of the day, we're in support of the vaccine. There's another slide I want to look at, because it isn't just, well, Dr. Walks thinks it's a good idea and Dr. Maxey thinks it's a good idea. It's also the fact that we have brilliant, nationally recognized folks that just happen to look like us, that have amazing and tremendous credentials, who have gone through the science of this. We'll hear from Dr. Despani later, superb, ultimate scientist. But we have other folks that are on this slide who are scientists that have been part of the going through the research around the vaccines, and then reviewing the research, and then being able to make comments. One of the folks that was with us on the Black Health Trust a few weeks ago, Dr. Leon McDougall, head of the National Medical Association, was able to distill for us the work that NMA has done, shadowing, looking over, and then ultimately approving the recommendations from the FDA for the emergency use authorization for the existing vaccines that we have, the Pfizer vaccine and the Moderna vaccine. So I want us to be confident that there is science and there are people who look like us behind recommendations for the vaccine. At the end of the day, we encourage folks to talk to their doctors and to get that local advice, because who do we trust more? The previous slide showed, we trust our doctors and nurses. And with that, I'll turn it back to you, Dr. Maxey.
Thank you very much, Dr. Walks. Dr. Nabert Stevens, you want to introduce?
All right, with that introduction to the, and sort of setting the stage for today's program, we're going to ask that Dr. Archie join us now and talk to us about COVID and pregnancy. While she's getting her slide and unmuted, Dr. Archie is an OBGYN in Los Angeles and is affiliated with multiple hospitals in the area. She has been in practice for more than 20 years and is going to share with us her experience and advice regarding pregnancy and COVID.
Thank you so very much for that, the invitation to be here. It's my first time here, so I'm a little new to it, but I'm so happy to share information with women who may be pregnant or recently pregnant or thinking about getting pregnant, because it's very important for you guys to be as healthy as you can going into pregnancy, going through pregnancy, and as a mom, I want you for the rest of your life. And it's a great opportunity to enhance your health habits. And among those health habits is getting appropriate vaccinations. As has already been discussed, COVID-19 has been devastating to our community, and it does not spare pregnant women. So I'm going to go through a few slides. Are the slides available? So as we know, COVID-19 is a disease that affects breathing and our lungs. And the symptoms are very diverse, sometimes quite subtle, sometimes they can be severe. Hopefully, when you recognize you might have some symptoms that are consistent with COVID-19, you will call your doctor and arrange to be evaluated. Next slide, please. So research is still ongoing into how this disease affects pregnant women in particular, but we do know that, or it seems that pregnant women may be at a higher risk for more severe illness than non-pregnant women. Pregnant women who have COVID-19 symptoms are a little bit more likely to go into an intensive care unit and need a ventilator. So it is something that, of course, we want to avoid. Next slide, please. As with any group of people, if you have pre-existing health conditions, you are more likely to have severe illness with this virus. So women with obesity, hypertension, diabetes, or gestational diabetes, all of these women are more likely to be in serious trouble when they're infected. But have no fear. Next slide, please. Just as in the general population, Black and Hispanic people are harder hit by this illness than the general population. And it's really devastating, particularly in Los Angeles, where we're currently maybe just coming out of a huge surge. Next slide, please. We do know some things that that the fetus is can be infected if the mother is infected, but it appears to be a very rare occurrence. But it is, of course, safest for any fetus if the mom's optimally healthy. Next slide, please. It may complicate a pregnancy and increase the risk of preterm birth, perhaps stillbirth. But the studies are still ongoing. And as African American people, we already have a higher risk of preterm birth and stillbirth. We generally have less good pregnancy outcomes than do non-African American populations. Next slide, please. And if exposed after birth, a newborn can. So going back to what was said previously, you need to do all of the preventive measures that we are supposed to do in general, with particular attention to detail when you're caring for your newborn. So using your mask, babies can't be masked, so you use your mask, you do your hand washing all the time, and always show social distance. Next slide, please. And so the question of the moment is, should you get a COVID-19 vaccine during pregnancy? I say in general that if you are in the groups that are very likely to be infected, you should be vaccinated. So all of our nurses, all of our doctors who are pregnant or parenting, newborns need to be vaccinated. But of course, people wonder, well, is it safe? Next slide, please. These vaccines have been thoroughly tested in the standard scientific method that we use for establishing the safety of vaccines. They've been developed more swiftly because they have been, we are using the cutting edge science that allows us to not have had the really long development period when we were first learning about vaccination. So it is logical that we should be better at grasping the understanding, the underlying science of virology, and we were able to come up with the vaccine. But the testing in terms of safety has been the same. The standards have not been lowered. Okay, next slide, please. It is true that the testing was not done specifically on pregnant women. And that doesn't mean pregnant women haven't been vaccinated, because, pregnancy happens. And in those cases, we have not seen any adverse impact on pregnancy. And there is no reason to expect that, given what we know about other vaccines, how they work in the body, and this particular vaccine. So it's not been specifically studied in pregnant women, but there's no reason to expect there's an elevated risk to a pregnant woman. And I believe strongly that it's protective of the woman and her fetus. And I would advise you to seriously consider, I would tell you that you really should be vaccinated, particularly if you're working in an area or in a situation where you might be more likely to have exposure to this illness. Next slide. If you are vaccinated, I think it's important for you to understand that if you have some mild symptoms that are similar to a flu, that's a normal. That's happening because your body is actually doing the job we're asking of vaccines. You have to know that vaccines do not give you protection against a virus. They give your body the information it needs to create its own protection. And that's where sometimes symptoms come in. I will just say that generally, a lot of us just don't have any symptoms, at least with the first dose of the vaccines that currently did. I didn't, and I'm kind of an old lady, so there you go. But you can use over-the-counter medications that are safe in pregnancy if you happen to have them. If you have a fever, if you have a little body aches, you can use acetaminophen, which is Tylenol, which is known to be safe in pregnancy. And always, always hydrate well. Always, vaccine or no. And if you have more than what you think are expected side effects, contact your doctor. Next slide, please. Well, I think we all know about the basic protective measures, and that needs to happen. So even if you're not in a high-risk group and you're not going to be vaccinated right away, please use all the tools that we've been given in terms of face masks, social distancing, washing our hands, all those things. Some women have been wondering if they should still come to the doctor during the pregnancy. And the doctor may be modifying how often they see you, but you definitely need to stay in touch with your obstetrician or healthcare provider and go to the office when the appointments are needed. Some appointments can be handled over the telephone, mostly, but not with OBGYN. You actually have to be there so that the doctor can see you. But your doctor will, or certainly should, be taking all the precautions to make the office a safe space. When you enter, you should see that there's room for everyone to have social distancing. You should know that and notice that everyone's washing their hands, that everyone's wearing a mask, that you have to evaluate and know that you're in a safe space. And if you have any concerns, speak with your doctor about that. Like, how are you making this visit safe for me? It's all right to ask. I always want my patients to ask if they have any questions. Next slide, please. And then there may be many, many more questions that you have during this time of COVID. In our practice, we are always working on stress management, and we do know that anxiety and depression seems to be, which had been under control before, may be less under control. As a maternal fetal medicine specialist, I manage patients with and help general OBs manage patients with underlying conditions. So medication can be and is safely used for anxiety, depression. But also, I like all of my patients, whether they have any clinical diagnosis of that sort, to know that managing stress is something that we all need to do better. And part of that is eating well, and we go over healthy eating with all the patients that I see, whether they're there because they have high blood pressure and diabetes, or they're there because they have asthma or any other kind of underlying conditions. We talk about getting the protein you need, getting the vegetables you need, getting the hydration you need, and getting exercise every day. In these stressful situations, it's also known that abuse at home can sometimes increase, especially when you're not able to get out as much and have space. If you have any concerns that you're being abused, there are some phone numbers that I've printed here, and just let your doctor know. Let your doctor know, because he or she should be able and willing to help you. There are many ways in which COVID makes all of our underlying problems worse. But your pregnancy should be, and still should be, a very happy and joyful time. But you just have to take control of making really good choices in terms of managing your health and well-being. I have quite a few more slides, but I would be open to having questions from anyone who has questions at this point.
Thank you, Dr. Archie. I do have a question, and two questions actually. One, in this time of COVID, should it affect a young woman's choice to try to get pregnant? One, and then two, even though I know you're not a pediatrician, but you're in the area, when you have a child, how do you protect that child from a COVID environment? I know they can't wear masks, they can't do what we do. So if you'd address those two, I'd appreciate it.
Absolutely. If you'd asked me early in the pandemic, well, maybe I would say, yeah, I would wait because it's going to be over soon. But I don't know when this is going to be over. So I think that we need to go forward and live our lives. If this is the right time in your life for you to have a baby, you should do so without fear, but with care to how you take care of yourself. So the vaccination I would get sooner rather than later if I was in a position to do that. But once we're all vaccinated, that doesn't mean it's going you can give up being extra careful. So yes, go on with your life. If you found the love of your life and you feel ready to be a parent, go for it. But keep doing all the things that we ask you to do to keep yourself safe. And your fetus, should you conceive, is part of yourself. So that you have to love yourself as much as you would love any baby and do the right things there. In terms of the baby, you're going to definitely Make sure that you go to the doctor when you need to go to the doctor for the baby's well baby checks or any concerns around your baby. Again, the doctor will be providing a safe environment for those patients that need to come. Part of that is that those patients that don't need to come are taken care of by, distance over the internet. But you have to have space, you have to have a clean environment, and you wear your mask. You avoid going out when you don't have to go out. You stay at home and you make sure that your home is a safe environment. So life has to go on, and it can go on. We just have to be diligent about self-care. Are there any?
Dr. Neighbor-Stevens, as a pediatrician, do you have any comments or questions of Dr. Archie? And Michelle be looking at the chat box.
Well, I think that she gave a very good answer to your question about what to do about the baby who obviously can't wear a mask. I had to smile when I was listening to her talk. I was thinking about what I used to hear my grandmother say all the time when we would be out and about, and she would run into a family that had obviously a baby that was less than 6 weeks old out in the shopping center, which I guess we don't go to anymore, but in the shopping mall. And the question was, why does she have that baby out in this shopping center? There are certainly socioeconomic reasons why maybe she didn't have access to a babysitter, and she needed to go to the shopping center. But at this point in time, as I said before, probably none of us need to be in the shopping center. We need to think seriously and with all seriousness, be very particular in where we take our children, not only the little babies, but even the ones under 3 that are not going to be masked, which then kind of goes into a topic that I addressed back in September, and we're going to have to address again pretty soon. And that's this whole issue of children and going to school in face-to-face classroom learning. So stay tuned for that conversation. But yeah, you want to socially distance and avoid taking the babies out unless you just absolutely have to.
Michelle, are there any questions in the chat box?
Just one here. So it's a general question, but certainly inclusive of pregnant women or women who are thinking about being pregnant. So the question is it more important to get a COVID vaccine than a flu vaccine at this point?
I saw that question in the chat box, and I was glad that they asked that question. Dr. Archie, do you want to respond?
Well, I try very hard to get every single pregnant woman vaccinated against influenza. I think it's, even without COVID, we know that this is a virus that does pass through the placenta and can infect a fetus inside. We do know that the vaccine is safe for pregnancy and pregnant women, and it's very powerful. Vaccines, just like the vaccine for COVID, does not give you immunity. It only allows your own body to create the natural immunity against this, and you share it with the baby inside you. And as you're breastfeeding the baby, which I know you are probably like me, really encourage our ladies to do, you should continue to share that immunity during the first 6 months or so of their lives when they are so vulnerable. So it's just empowering your body to do what all moms' bodies do: nourish and protect the baby.
You raised an important point and I remember back about 100 years ago when I was in medical school, if a pregnant woman has received vaccine, let's say 2 months ago, when she gives birth, how much of that immunity, if any, is shared with that new baby?
The best way, the only efficient way to share your immunity with the baby once the baby's born is to breastfeed. And it's really not just, for a lot of women, just an easy thing to do. So I always start talking with them about hydration and nutrition and about asking for help before they get out of the hospital about how to initiate the breastfeeding, because people get so discouraged right there in the hospital when it's not automatic. But it can be a learning process. So I want to encourage patients to demand to be taught. And if a nurse comes in and says, "Oh, you're having trouble, here's a bottle," you say, "I am a breastfeeding mom." And they need to be able to stand up for their right to be taught and helped in that situation.
Yeah. That's everything. Question?
No, we don't have any more questions
Can I ask
for
you?
Archie right now, but we could move
May I-
on
may I
to
ask
your
you a question?
surprise.
I want one last question, and that is, if you have not received the vaccine
Mhm.
and you're pregnant and you're near term and you do get COVID, can you then breastfeed? Is that virus going to be passed on to that baby in a non-immunized mother?
We don't really know that much about the passage of the vaccine, of the virus from the mom to the fetus or to the baby. And I don't think that the vaccination is the critical issue. The vaccine won't keep you from being infected. It will allow you to manage an infection so it doesn't get out of control. So I still, my instinct is that the healthy mom should breastfeed a healthy baby. And there are so many things in terms of optimal nutrition and the store of the mother's memory of immunity in the breast milk, that I think as long as you're not ill and coughing on the baby, you can't do that. You have to be separated when you're really symptomatic, but you can pump until you're ready to put it back in the breast, baby back to the breast, and the breast milk can be given to the baby by the person who's helping you with the baby. So
I'd like to introduce for a few moments a physician who, thank you so much, Dr. Archie. I appreciate your lecture.
absolutely.
And I'd
Thank you so much for having me.
But years ago when I was in medical school, I met a very distinguished physician. At the time I met him, he was the Associate Dean of the College of Medicine at Harvard University. He was a cardiologist. In fact, he was in charge of the EKG laboratory at Harvard. And he was recruiting young, and I emphasize that word since Dr. Ivan Walsh gave me the title of young, recruiting young Black physicians to come to the Harvard hospitals for their residencies and internships. He went on to be the founder of the Association of Black Cardiologists. Most recently has been the president of the National Medical Association. I'd like to recognize for a few moments of appropriate comments, before we move to other speakers, Dr. Richard Allen Williams.
Good afternoon, everyone. Thank you very much for that sterling introduction, Randall, my former mentee, and got some other mentees on this program, including Dr. Jesse Sherrod, who is there. I'm going to just take 1 minute to intervene in this great program. First, to say how fantastic this is that we're coming together every Sunday to address these issues regarding COVID-19, and especially with relevance to the Black population. At this particular time, I want to impose upon you a thought that we need to stop, look around us, take a deep breath, and realize that we're in what I call the urgency of now. And what I mean by that is that we're facing, no matter what we look at in regards to this COVID-19 situation, we're facing the fact that Black people are not getting vaccinated at a great enough clip to be protective for us. And there are several reasons for that, one of which is the fact that there's a culture which has been developed to tell Black people that they should not accept the vaccine, which I think is something that we need to rail against. Many of you may have different thoughts about that, but the overall importance of this is that if Black people don't get vaccinated in sufficient numbers, not only will they endanger others, but they'll be, of course, endangered themselves. That's my thought about that. I want to point out one thing in particular that emphasizes that situation. Last week, the Baseball Hall of Famer and great Hank Aaron passed away. And everybody was of course, very sorrowful about that. On top of his passing away, there was a statement that came out from a gentleman named Robert F. Kennedy, indicating that Hank Aaron had received the COVID vaccine 18 days before he died. The implication was that that's the reason that he died, that he received the vaccination. Many of you may not have heard about that, but you need to hear about that and understand what is going around in regards to misinformation and attempts to dissuade Black people from taking this vaccine. And we need to take some steps in regards to that. So I wanted to talk about what we are facing as a challenge right now in the moment. There's several challenges, one of which has to do with the fact that we are facing the problem of increased vaccine approval, that is approval of things like the J&J vaccine and others that are coming forth, and that we need to encourage more vaccine approval. A second one that addresses this issue is the problem of vaccine rollout and distribution. I'm on the county commission that has to do with helping out in that situation. And believe me, we recognize that this is a problem not only in LA County, but nationwide, which the Biden administration is trying to take up on. Then there's a problem of enough vaccine sites. We don't have enough sites identified. All of these logistical problems we're facing. Another one is not having enough vaccinators. We need to train more people to give the shots, hoping that we'll get enough candidates, especially African American and other people of color as candidates, to come forth and accept getting that shot in their arm. So what we can do about that is, first of all, what is being done on this program, trying to provide facts so that we have transparency, which will lead to truth, and that will lead to trust. So if we look at those three things, those three T's, as being kind of consecutive, I think we'll win that battle. And finally, I just want to mention one common sense thing. You know, when I was growing up, my mama said, don't be too concerned about all these statistics and scientific information that you're learning in school and so on and so forth, at some point, you have to go back to your common sense, what we used to call mother wit. And one of these principles has to do with something that I'm going to present to you very briefly. Take a look at the statistics. You got 400,000 deaths in this country as of right now. As far as we know, and as far as we can document, there are 0 deaths due to vaccination. Now, of course, there have been some things that have been thrown around about somebody dying from the vaccine, like Hank Aaron and several others that have been perpetrated. But I just throw out to your self-reasoning what it means to look at the possibility of allowing yourself to be exposed to that 400, being one of those 400,000 people and dying from the COVID vaccine, the COVID virus, versus taking, if you want to, the chance of getting vaccinated. Doesn't that make sense to you, common sense wise? Okay, so I can't put it any blunter, but the final thing that I want to mention is that we need to take some steps to get more facts out to people. And Dr. Walks mentioned that doctors and nurses and other healthcare practitioners are very much trusted in our community. And we can increase that sense of trust by organizing, by having a coalition of all of our organizations, especially medical organizations, to the point of being able to take a common message out to our Black folks, okay? Let them know that our Black doctors are behind the vaccine and that we want them to go out and find that vaccine and get vaccinated, if they can find it. You know that there are problems right now. But don't deny something that's going to save your life. We need to get that very, very blunt message out to folks. And so I talked to Dr. Maxey this morning, and we're going to get that organizational coalition formed so that we as medical practitioners and healthcare providers can go out to our people and give them that transparency, truth, and lead to the trust that they need to develop in regards to this vaccination process. Thank you very much.
Thank you much, Dr. Williams. We certainly appreciate that. I look forward to speaking with you. And I'm going to ask Dr. Nabrett to introduce, we're very fortunate. We got 2 full professors at UCLA on the program today. One is you, Dr. Williams. And then on the other end of the spectrum, we have the young one, the young full professor at UCLA as our next speaker. Dr. Nabrett Stephens, would you introduce in detail Dr. Keith Norris, please?
Thank you. I certainly will, but I have to say that I am just really honored that you are giving me the opportunity to introduce him, because you've been telling me about him for some time, and I am really honored to be able to make this presentation.
Well, I have to tell a story real quick. I asked Dr. Norris to fax me his CV some years ago. He said, Maxie, you don't have enough paper in your fax machine. But go ahead and introduce me.
Okay, that's a hard thing to come behind, but Dr. Norris is an internationally recognized clinician, scientist, and health policy leader who has made major contributions to diversity, equity, and inclusion while addressing disparities in contemporary society. His main clinical interests revolve around chronic kidney disease and the impact of the many comorbid conditions that usually ride along with it, such as diabetes, hypertension, and vitamin D deficiency. He is currently, and I'm hoping that he will make some comments about this activity as well. He is currently working very closely with Dr. Arlene Brown at UCLA on an NIH-funded project called COVID-19 California Alliance, called Stop COVID-19 CA. A major goal of Stop COVID-19 CA is to work with a network of community and academic partnerships across the state to improve COVID-19 knowledge and increase participation of all Californians, including underrepresented populations, in the prevention regarding vaccine and therapeutic trials, and to improve the uptake of approved vaccines. This activity that he is currently involved in is another example of the work that's being done at the grassroots level. And we have been particularly fortunate in being able to bring representatives who are engaged in local activity around COVID to this forum. And so we'll be very interested to hear what's going on in California. So without further ado, I turn it over to Dr. Norris. Simon, can you take him off of mute?
Good afternoon. So I just want, good afternoon again, everybody. Pleasure to be here and to see many friends and some people I don't know. And I'll just talk for a few minutes on vitamin D and COVID, and then I'll talk a little bit about this new grant we have and open it up for Q&A. So what I wanted to do, so this came out on MedPage about a little more than 10 days ago. And this is a federal crackdown on vitamin D COVID cures, right? So Georgia-based company ordered to stop sales after a national recall. And so again, I just want everybody to be careful. We don't have any cures for COVID. Nothing we have is a cure. We have 0 cures. We have some things that are helpful. We have some things that are questionable. We have some things we pretty much know don't work at all. Okay, but we have no cures. And vitamin D is not one of them. And I'm a very big avid vitamin D person, but it's not a cure. Okay. So why are we worried about low vitamin D during the pandemic? First of all, everybody's told to stay inside. So if you're inside, you're not getting much sunlight, you're gonna have lower vitamin D. And when you are outside, you have a face mask on, right? So you're gonna get less exposure to sunlight, and therefore less ability to convert pre-vitamin D to vitamin D because of sunlight. And then with less physical activity, a lot of people are gaining weight, and then your serum vitamin D is more likely to be moving to fat stores rather than circulating. So all these things can lead to lower vitamin D levels. And then to start out with, when we think about COVID and who COVID's affecting, older people, people with chronic diseases usually have lower serum vitamin D levels, as do Black individuals. So there've been a little more than 15 studies to date looking at the association between vitamin D levels and COVID-19. And this has spurred a lot of the reports and recommendations. And there was a recent recommendation from a group of thought leaders with vitamin D proposing, recommending vitamin D. And what we see is the lower the vitamin D levels, the worse the outcome. So levels less than 10 nanograms per milliliter, and normally should be greater than 30. So if it's very low, less than 10, greater risk for death. Less than 20, but greater than 10, greater risk for severe COVID disease. Less than 25, moderate COVID disease, and then more mild disease when it's above 30. But we also know sicker people tend to have lower vitamin D, 25D levels. So it's not, it doesn't say that having low vitamin D means you're going to get necessarily sicker or have a worse course with vitamin D. And this got a little, so there was a study out of Spain where they randomized individuals admitted to the hospital with or without giving them vitamin D. And everybody was getting standard care, which at the time was azithromycin or hydroxychloroquine, which is now no longer standard treatment. But at the time, those that got vitamin D were less likely to require ICU and less likely to die. And so because of this study, this really promoted a lot of people to start thinking about and recommending vitamin D. But this was just a pilot study. So although it was randomized, it wasn't really well controlled. And since then, we don't really have any significant, we've had several studies, randomized studies that have not shown any efficacy. And there are others that are being initiated soon. This recent article from Dr. Fauci said treatment for outpatients with mild disease must be safe, with few adverse effects, easy to administer, and scalable. And what we do know is vitamin D is pretty safe, it's pretty easy to administer, and it's easy to scale. So those are the plus sides for vitamin D. A variety of therapies have been proposed for early intervention for COVID. Fluvoxamine, which is usually more for mental health conditions. Ivermectin, hydroxychloroquine, and vitamin D. The NIH has recently, the NIH sort of advisory panel has said hydroxychloroquine is no longer considered even a possible. The others are sort of considered possible, but not definitive. But in my mind, if you have something that's possible, you want it to have like no side effects, right? And these other drugs do have side effects. Vitamin D doesn't really. And also for a variety of reasons, vitamin D, like in the general population, if you're otherwise healthy, having low vitamin D probably doesn't cause a lot of problems. But if you have other problems, such as diabetes, high blood pressure, the stresses that are going on with being in the middle of a pandemic, all of these other, I would say, stressors or comorbidities probably are the situation where having low vitamin D in addition may be even more likely to potentially impact your immune system. So in thinking about when one might recommend vitamin D for individuals in the middle of a pandemic with a viral illness, people who probably are going to respond better to vitamin D are those who have increased risk, those older, diabetes, hypertension, obesity, heart disease. But again, as of right now, the clinical trials that have been done have not consistently shown any benefit, and probably more trials have not shown benefit than have shown benefit. So as of right now, it is not recommended as a treatment, and no data to say it is necessarily preventive. On the other hand, we know the normal recommendation for vitamin D from the Institute of Medicine is 600 international units a day, but up to 4,000 international units a day. So while we don't know, while there's no data that it is actually effective, there's really no harm in probably giving or recommending 1,000 to 4,000 a day seems appropriate, particularly for people of color who are more likely to have lower vitamin D levels, and in the small amount of sun exposure they get, are less likely to be able to generate active vitamin D. And then again, there's no evidence yet that it helps, but it probably won't hurt. So I take 2,000 international units of vitamin D a day. And I think that's probably a very reasonable approach. I think it's reasonable for us to recommend, to make sure people are not becoming vitamin D deficient because of the pandemic and whatever risk that might have. But I think we should not, while I think it's appropriate to recommend vitamin D, we should not be saying we want you to take vitamin D because we know it's preventive, because we know it's an effective treatment early on. But what we do know is that there may or may not be some benefit, but we know during the pandemic, your levels could get low. It's good to get them back up to normal. And this seems like a reasonable amount. So thank you for your attention to this. The 3 W's: wash your hands, watch your distance, wear a face covering, or give that as a reminder. And then regarding the NIH project, so we recently received funding from NIH for a statewide initiative that we lead, and it's a collaborative project between 10 other institutions in California, and then about 70 community partners right now. So these are different community partners who have already been working with these institutions. It includes UC Davis, Stanford, UC San Francisco, UC Merced, UC Riverside, UC Irvine, USC, Scripps, San Diego State, and UC San Diego, in addition to UCLA. So we all work with a variety of different community partners, and it's a combination of doing different strategies and approaches for gaining information, for disseminating information in different communities, both rural communities such as farm communities, many of those in the Latinx community working in farm areas in Central California, to urban areas from Compton and Watts to different communities in Northern California and in San Diego. So Dr. Maxey and I have chatted briefly about this earlier today, and so we'll have more discussion to figure out how we might be able to work with and do partnering with the Black Health Trust as part of this, and I will open it up to questions. Thank you.
Thank you very much, Dr. Keith Norris. I have a brand new fax machine just for you. It's electronic. Papers that you want can go into it. A couple of questions while they're looking at the chat box. Just how does, if it does, vitamin D work to improve the immune system? And is there any such thing as vitamin D toxicity? And
So-
third question, is there increased risk for a patient with chronic kidney disease or kidney failure?
So vitamin D toxicity you can get, but that's very difficult. Usually that's what people are taking tens of thousands, over 10,000 units a day or even more than that. And so that's not something we usually see. And usually there was a mistake. Someone's taking, instead of 50,000 international units a week for 8 weeks to get up and go in there, taking it every day for long periods of time. For patients with chronic kidney disease, we don't really know what the dose of vitamin D or what type of vitamin D. So that one study used 25 vitamin D, and we don't know if 25 vitamin D or 125 vitamin D might work or might not work for patients with kidney disease. So that's something that's being tossed around. There's a couple studies that are being initiated soon. How does it work? How does vitamin D work on the immune system? So there is, on the cell, there are these receptors called toll receptors. and the virus sort of connects and activates the toll receptor, and it activates a variety of substances in the cell, including cathelicidin. And part of the control of cathelicidin and some other immune factors within the cell are also regulated by vitamin D. And so if you have enough cathelicidin, it helps the cells, particularly the immune cells, to capture and kill the virus. It was first really reported with tuberculosis, that people who have low levels of vitamin D are unable to kill the tuberculosis bacterium. So if you have low vitamin D, that pathway, as well as the oxidative stress pathway, because nitric oxide is part of this killing system per se for the viruses, and these are all somewhat regulated by vitamin D. So low vitamin D impairs the immune system. It reduces the ability of the cells to clear and destroy viruses as well as certain bacteria. And that's sort of why vitamin D sort of sits in this space of immune function and is considered a potential treatment in COVID, because it has, if it's very low, it can adversely affect one's innate immune system, and that therefore could put you at greater risk for some COVID.
Thank you, Dr. Nabrit and Michelle. Are there any questions in the?
And we do have some questions, and I'm glad they asked the question. The question was, how does carrying excess fat, since vitamin D is stored in fat, does it lead to any misleading test results? And then I would tack on to that, if you are an obese person, does that impact the amount of daily vitamin D you might consider taking as your daily supplement?
Right. So both great questions. So what we don't know for certain is, so because it's fat soluble, it can go into the fat stores. We don't know is, does it come out appropriately when it's needed, right? And so we do need to give probably a little more to get our serum levels up, but it's not clear, like if it's a little low, but you have more fat stores, is that adverse to your health? And so that is not really known yet. And that's where we are. I could make up more, but I'd be making it up.
So there was another question addressing geography, and I definitely would like to hear your response to this, because I had the opportunity. I'm not hating on the Northeast or the Midwest, but you do know that I live in Tampa now. I do know that I did note how few days the sun shone when I lived in Detroit and when I lived in Philadelphia. So the question in all seriousness is, even if you do happen to be a person who maybe goes outside to walk, if you live in those areas of the country where there are decreased number of days where it's nice and sunny, how does that figure into the whole supplement equation?
Right. Yeah, in a more northern latitude and with less sunlight, then you're at greater risk for having low vitamin D. And so while the Institute of Medicine tends to recommend 600 international units, my view is probably I would go with 1,000 normally. And now with COVID, I'm probably thinking more 2,000. And then also if you're at a northern latitude, the conversion, when sunlight reaches the skin and it activates pre-vitamin D to convert it to vitamin D, that reaction is temperature dependent. And the colder it is, the slower that reaction is. So when you're in the north, not only may you be exposed to less sunlight, but if the temperature is cold, then the sunlight you're exposed to is not going to, the amount of time that's needed to activate pre-vitamin D to vitamin D is greater because that reaction occurs slower. And so there's two reasons why being in northern latitude might increase one's risk for having lower vitamin D levels. And I would just, again, opt for making sure at least I'm taking 1,000 international units a day. And as I said, I personally take 2,000.
So there's another question around, I'm sorry, you want to do it, Michelle? Go ahead.
Oh, I'm sorry. I thought before you transitioned, I just want to make sure we got to a couple of these. And I also wanted to acknowledge Dr. Archie, who may have a question regarding this topic. So while she's unmuting, we will say, what is the protocol, Dr. Norris, for rapidly increasing vitamin D levels to within normal levels?
So what we do, so for our patients with kidney disease who may have very, very low levels, we usually give 50,000 international units once a week for like 8 weeks.
Okay.
And that's a way to get it up and get it up really high in a short period of time.
Okay.
But usually we see that in people who actually have like major problems from low vitamin D, such as significant bone disease, osteomalacia, or some other problems. So I don't think it's as necessary to have to get it up at, in someone who's otherwise healthy and they have low vitamin D. I don't think they absolutely need that much that quickly to get it up. They could probably take 10, 20,000 units a week for a couple weeks and they'd be fine.
Understood. Thank you.
I see the question, is vitamin D3 supplement the correct supplement to use? So you can use either vitamin D2 or vitamin D3. They're pretty much the same. D3 it's felt that you may not need quite as much D3, but they're pretty much the same. And that's, I think, sort of semantic. So either D2 or D3 is probably fine.
Thank you, Dr. Norris. Dr. Archie, would you like to jump in there?
Yes, I just wanted to say that that in pregnancy, vitamin D deficiency or lower levels tend to present as pruritus, generalized pruritus. And that's really important in pregnancy because when you present with generalized pruritus in pregnancy, most OBs think of an illness that will cause fetuses to die in utero, actually. So
When you say pruritus?
just generalized pruritus, they itch.
Okay.
And and we discovered the link through a patient who found that people in chat rooms were talking about itching in pregnancy and they got better with vitamin D. So we tested it by patients who were presenting with those things. You can do the serum levels, and sure enough, we found a good percentage of those women who presented that way actually had vitamin D deficiency. And when we gave them vitamin D supplementation, the itch went away. And we spared them from going down the rabbit hole where they were going to be tested and maybe delivered earlier because it's a similar presentation. What I don't know is if there's, and I don't think it's been studied in pregnancy, whether there's a general tendency to get vitamin D deficiency. And I didn't know if you knew that.
Well,
Yeah.
let me add to that question. And I'm going to throw this to Dr. Norris. Is that a deposit of calcium phosphate, as we know about in renal disease? What might that be?
Yeah, I don't know why pruritus would occur, and I don't know if there's any risk, why someone would have less vitamin D levels during pregnancy above and beyond the normal population. Maybe, I don't know, maybe if people start developing, certain eating patterns and habits, and they're not eating certain foods that might be fortified, or not going out But I don't, other than that, I can't really say. Now, for the general population, signs and symptoms of low vitamin D, very vague, very diffuse, nothing really that we know of, but I know a lot of endocrinologists who tell me that they have patients who have myalgias and pains and aches and when they've been found to have low vitamin D, and when they've been treated, they've had marked improvements in their symptoms. So I don't think there's been any controlled studies looking at that, but I've heard of it commonly enough. And what's important for you as a person, if it works for you, that's what's important for you, right?
So Dr. Norris, there's a question in the chat regarding the role of melanin and vitamin D absorption and prevalence of vitamin D deficiency, even when there is significant melanin present in the individual. I know you touch on it very lightly in your talk, but could you go back and kind of explain that a little bit?
Yeah, and does that correlate with increased incidence of prostate cancer?
So
Now, that was a jump.
the more melanin, the more light sunlight exposure you need to generate the same amount of vitamin D, right? So that contributes to sort of that, and maybe having lactose insufficiency, since much of vitamin D fortification in our country is through dairy products. Those are probably two major reasons why we see lower vitamin D levels in the Black community. As far as its relationship to prostate cancer, really don't know. That's been brought up as a potential issue, and people have been trying to look at vitamin D as an adjunct treatment for prostate cancer, but hard to say. And so we just don't really know.
Thank you.
I see many of the others have been answered here.
Dr. Dawes has a question for you. She wants to know, she says that in patients admitted to COVID isolation ward in Jamaica, how much vitamin D would you recommend? Vitamin D levels are not measured there.
Yeah, so vitamin D levels cost a lot, and giving vitamin D is dirt cheap. And getting overdose in vitamin D is really hard to do. So if you give patients 2,000 units of vitamin D a day, that'll get their levels up in pretty quickly. If you want to go a little more aggressive, you can give 4,000 or 5,000, and you wouldn't have to worry about measuring vitamin D because you would not be causing any toxicity or anything.
Excellent, excellent. Any other questions, Michelle?
The only one, forgive me if we did cover this on some level, but should people with autoimmune disease have higher levels of vitamin D?
Should they have autoimmune? Not that I know of.
Okay, thank you, Dr. Norris.
Okay.
Thank you so much, Dr. Norris. We appreciate your talk and hope you can stick around for a little bit for questions. Sure. Dr. Neighbor, would you introduce Dr. Despani? However, I want to first give our, actually I'm going to ask Michelle to give our disclaimer again with all this information we're giving out, please.
I'd be happy to. So the Black Health Trust disclaimer reads as follows. Please note that the information communicated on this program is not intended or deemed to be medical or legal advice, and you should always consult your own medical or legal professional for advice and direction pertaining to your particular situation and needs. The information presented here is not advice, but rather opinions and recommendations from credible sources. Black Health Trust, its representatives, members, employees, attendees, heirs, assigns, and guest speakers and presenters assume no liability whatsoever in connection with the information presented or used by anyone, nor are these discussions directed to specific situations. Again, we strongly encourage all attendees of the program to consult their own legal or medical professional for conclusive guidance on how to proceed in your own personal circumstances.
Dr. Neighbor? Is Dr. Neighbor muted?
She, you know what, her screen is dark at the moment.
She's in Tennessee, across near where the AT&T got bombed a week ago. So
No,
let me go forward and introduce Dr. Jordan Despani.
terrific.
He's a PhD in virology, and he has lectured on a number of occasions on the basic science and tenets of virology and viral disease, and specifically COVID. And today he's going to present a short talk and answer questions, and he's calling it COVID-19 201. Dr. Despani.
Yeah, I believe, can everyone see my, I guess, PowerPoint presentation?
Not yet, Dr. Despani.
Can you put the slides up, Simon?
I believe it's on its way. There we go.
Okay, yeah, so thank you, Black Health Trust, for having me once more. And before I start, I would especially like to, again, give a hearty congratulations to Dr. Carol Archie. Believe it or not, but she actually has had a great deal of influencing, my moral compass as a biomedical scientist. So again, the man that I am is partly shaped by Dr. Archie. So the talk that I will be giving will be further elucidation of what I've discussed beforehand. That talk beforehand was titled Virology 101, the Mutational Landscape. So for this subtitle, it will be the evolving mutational landscape, now that we've seen that there are quite a myriad of different variants that are just spreading all across the world. And just to begin, first, we want to take stock of where we are with the SARS coronavirus 2 pandemic. And what you see here from the Johns Hopkins Coronavirus Resource Center is both the daily cases, cumulative cases, daily deaths, and cumulative deaths in a graphical context. And what you see in terms of the cumulative cases is that as of yesterday, we've reached 24.9 million cases total within this nation. And that is accompanied with 417,439 deaths. So these are sobering statistics that we have to get under control. But the reality is that we're not only facing logistical challenges, but also the fact that the variants of the virus are actually like evolving in real time. So we're essentially like facing off against a moving target. So, and basically, again, that the deaths continue to arise during the third wave, and we have to, I guess, balance all the different variants and all the multitude of different traits that they have and try to keep sense of them. It's almost akin to whack-a-mole, if you think about it. So one thing I wanted to first do is kind of explain what the difference is between a strain, a variant, and a mutation, because you want to be armed with the requisite knowledge to understand what's going on whenever people are discussing in the news, like, oh my God, a strain or a variant and mutation. And interestingly enough, strain is a term that's thrown around most often, yet it's very difficult to discuss any of the new mutations as strains, because a strain really is a viral subtype that actually exists within a larger viral family. So for instance, you have what's called Coronaviridae, which is a class of all the different coronaviruses. And then within that, you have like types of the virus that each have like similar traits, right? So, and that's a result of them having the genetic similarities as a result of their shared mutations, and then long-term adaptations within a host in question. For instance, with the with the SARS coronavirus 1 and SARS coronavirus 2 viruses, what you see is that they both evolved an affinity for infecting human respiratory tracts. Like that's their target within the host specifically. And the reason why is because they're binding to what's called the angiotensin converting enzyme receptor 2, or ACE2 for short. And again, you can even see in this electron micrograph that SARS coronavirus 1 and SARS coronavirus 2 are pretty much similar in terms of like their appearance under that electron micrograph. So, but the reality is that they would almost be considered like cousins of one another. And again, recall that the SARS coronavirus 1 was a pandemic that occurred between 2002 to 2003. And that was basically a self-limiting infection, not self-limiting infection rather, but the Chinese authorities were able to get the virus under control before it went global. Whereas with SARS coronavirus 2, it has mutations that again allow it to also target the human respiratory tract, but that one kind of got out of control and now it's mutating almost ad infinitum. Now, moving beyond like what an actual strain is, like we now want to define what is a variant. And a variant is simply any cluster of mutations that impart either beneficial, neutral, or negative traits within the virus in question. So, and what we're worried about right now with SARS coronavirus 2 is that we are encountering variants that increase the transmission rates and are also capable of antibody evasion, meaning that your the antibodies that are produced by your immune cells are just no longer able to recognize the variants containing these new mutations as readily as they were the original variants of the virus. So another interesting aspect is that these variants are actually also in competition with one another. This is in real time an instance of natural selection going on. And for an example of like how this looks, or at least from a scientist perspective, what is going on is that each of these points in this graph below are actually like different mutations that actually comprise like a clade, or what you would really call like a phylogenetic tree. So it's almost equivalent to like a family tree, like, oh yeah, this variant is related to this one and it has these similar mutations, but it doesn't have this, and so forth and so on. So it's like one strange screwed up I guess family tree, for lack of a better term. And what's interesting is that we've already seen this occur beforehand, actually, believe it or not, over the summer, because what happened is that with the SARS coronavirus 2, the original variant from Wuhan actually was able to spread, but it was eventually outcompeted by a mutation called D614G, which basically was a mutation of the that should be the aspartic acid, the D, to actually becoming a glycine. And for whatever reason, that single point mutation actually led to that variant becoming the dominant variant throughout the entire world. And as you can see in this, I guess, chart or graph from Nature, the D614G variants like eventually became encapsulated within all the SARS coronavirus 2 variants all across the world. And that was kind of like the first instance of like, okay, we now have a mutation that is being taken up by all variants, and it imparts some type of benefit in human hosts that we don't really know of, except to say that it likely improves its ability to bind to human receptors. Again, those ACE2 receptors I discussed earlier. And then finally, to get down to the, I guess, the most fundamental level, again, like those variants are actually capable of being able to have differences, again, due to the point mutations. And point mutations are basically just a change within the genetic code of the virus that goes on to influence the amino acid composition and the resulting viral properties. And that's something that I discussed beforehand through a process of antigenic drift. all antigenic drift is the point mutations that a virus gains over time, and that actually causes problems for the immune system. And again, you see here with this cartoon, basically that the viral receptors, in the case of SARS coronavirus 2 and SARS coronavirus 1, actually, it's the spike protein that we need to pay attention to that actually gains these genetic mutations that then change the shape and maybe even function of the spike protein. And then afterwards, it now it's different in some way. And again, what's very important about those point mutations is that they could lead to antibodies from our own immune system that are not able to bind the virus as effectively. Again, a loss of vaccine efficacy, because basically the antibody that as it's about to bind to the epitope is what it's called of the virus is just like, oh, I can't, recognize you as well. So the binding won't be as tight. And what's even worse is this idea that you have a variant that completely abolishes the viral recognition altogether. And then that is actually what we assume might be behind the cases of reinfection. So just to illustrate in a cartoon, the idea of like immune evasion of the modified viral variant, what you have is you have an original strain, again, as with like a vaccine from either Pfizer or Moderna, and that can actually be recognized. But then again, the virus evolves what are called escape mutations that, again, they allow the virus epitope to not be bound as tightly by the antibodies generated by the immune system. So again, like you have less recognition as apparent by less immunoglobulins, aka antibodies, able to bind to that strain, and then again it loses you lose that efficacy, or again, like you can actually be reinfected. So that now brings me to the three predominant strains that have been all across the news that I want to go and brief on. The first being the British SARS coronavirus 2 variant that actually, again, came from or at least it was first identified as being a different variant by the time it had reached the United Kingdom, and it was first detected in September of 2020. And the biggest risk or fear that we have is that this British variant will cause increased transmissibility or enhance the transmission rates. And the reason why that's the case is because this British SARS coronavirus 2 variant possesses what's called the N501Y point mutation. So this is one tiny mutation of an asparagine at the 501st, I guess, site of the total viral genome. It gets converted into a tyrosine, and interestingly enough, that point mutation was originally first found in Italian samples on March 19 of 2020. So it was kind of like a prelude of things to come, unfortunately. But again, in the game of evolution, I suppose, the reality is that any mutation that I guess gives a benefit for the resulting viruses, it just takes up, that's in a complete random process. It's not like it's doing this because it knows something that we don't. It's just all like random, chance. And what's especially interesting about the N501Y mutation is that it occurs in what's called the receptor binding domain of the spike protein. And the spike protein is actually what the virus uses to bind to your ACE2 receptors. And what we have seen through experimental studies is that the N501Y mutation, it actually allows the spike protein of those modified viruses or variants to actually bind more tightly to our ACE2 receptors. And that's actually why many, I guess, clinicians as well as government officials and the like have stated that there's a risk of an increased transmission rates, even if there's not a concomitant increase in the mortality rate. Just alone, the fact of the matter is that if you have increased infectivity, then you're going to overburden the hospitals and the number of beds available, et cetera, et cetera. So that's one of the first variants that came under investigation that had the world frightened. And then in tandem with that, there was also another strain, the South African variant. I'm sorry, another variant, the South African variant that was identified a month later in October of 2020, and that actually has the downside of increased transmissibility, owing to the fact that it also shares the N501Y mutation with the British variant, and it also contains a E484K point mutation. Now, the E, just so you know, is basically a I guess short form to let scientists know that that's a glutamic acid at that position that's now being mutated to lysine. And this is very interesting, even from like a evolutionary perspective, because a glutamic acid is basically an acidic residue, whereas a lysine is actually a basic residue. So the fact that it's changing its entire charge indicates that it's really going at work, evolutionarily speaking, in order to try to ensure that it can bind even more tightly to the ACE2 receptor of the host. So that point mutation, the E484K point mutation, has actually been identified in studies as legitimately being an escape mutation that renders the FDA-approved antibody therapeutics less effective, or in this case, even completely ineffective in certain instances. So many clinicians, as well as scientists and government officials, are worried because, okay, you have something that not only can bind tighter to ensure or increase transmissibility, but you're also adding on top of this fear that your immune system won't even be able to recognize it as effectively, if at all. Now, just to clarify, though, that Pfizer and Moderna have tested it, at least their vaccine candidates, at least against the N501Y point mutation, and it seems to still be efficacious. But again, we still need to run more tests to determine how it will fare against this E484K point mutation. And then lastly, we also have another variant, aka the Brazilian / Japanese SARS coronavirus 2 variant. And the reason why it's, I guess it shares countries of origins, derives from the fact that it was first found in January 2021, and Brazilian patients that were traveling to Japan, and the Japanese authorities had actually run tests and determined like, hey, yeah, this is a new variant. And again, just akin to the fears that we share with the South African variant, is that this Brazilian / Japanese variant also has both the N501Y and E484K point mutations. So again, there's that risk of enhanced transmission rates as well as immuno evasion. So that's kind of where we stand, at least on knowing about variants that have at least undergone more investigation from the research community. But the reality is that there are now a fusillade, for lack of a better term, of other variants that are emerging. In fact, in Ohio, there have been 2 new variants that have been identified. There was another variant identified in Washington State. And then most pressingly, for many of the audience members here, is that there are also variants that have been identified in Los Angeles itself.
Dr. Deshpande,
Yes.
I'd like to ask you a question. My friend's grandmother is visiting me, and she is about to get vaccinated. And she's concerned that will these vaccines that she's about to get, whether it's Moderna or Pfizer, how will it be affected or not affected by the current identified variants?
Yeah. So as I just pointed out, the N501Y point mutation is the vaccine candidates that we have still work smashingly well against the N501Y point mutation, but we don't know for E484K. So
Acid though.
yeah, so I mean, I think probably like I mean, the best bet is always still to try to like have some efficacy of some vaccine efficacy by receiving the injection, the 2-course regimen. But I would not ever say that the any point mutation will reduce the efficacy rate to 0, but it will be decreased. So I still think that it would behoove your friend in question to still get vaccinated for protection, even though that might not be 100% efficacious. In fact, I do also want to clarify that the vaccine candidates from Pfizer and Moderna, like no one expected that they would have approximately 95% efficacy rates, because even with the influenza virus vaccines, those typically have they typically max out at between 50% efficacy rates, right? Most influenza virus vaccine candidates from year over year are within the range of 30 to 50% efficacy. So keep that in mind as well. So again, you will see,
you know, the topic of the mutations and what are our options are certainly top of mind. But I want to emphasize that we need to be guided by the facts. And unfortunately, all of this is like super new. So there are not a lot of facts that are known.
Mhm.
But one true fact is that right now we only have, if it's available in your area, the choice between Pfizer and Moderna. It is expected that Johnson & Johnson will be making an application for emergency use authorization either at the end of February or in March. But until that happens, their data is not available. But one of the things I'm sure that all of the experts and scientists will be looking at, but the public can also be looking to see, is given that their application will be made after the appearance of these variants, if in fact they are doing any testing to address their ability to be effective against the variant. So that is something that I would encourage everyone to be paying attention for information regarding their effectiveness against the variants. Now, as far as the question, and there have been several versions of this question in chat, of whether or not Pfizer and Moderna are going to be effective. What has been published is that they think that it will be. But again, we need to be led and guided by what actual factual data is presented. But the point that I have heard Dr. Fauci make in a couple of interviews in the last week is that all of this is even more reason, not that the avoiding of the deaths is not reason enough, but all of this is even more reason for us to, and when I say us now, I mean, at this point, it would be the government, to get our vaccine program on solid legs, get vaccine production and distribution achieved at the local level so that all of us can get the vaccine in our arm as soon as possible. Because if you can suppress the amount of infection in the community and in the world, then you can decrease the opportunity for the virus to evolve. So we all have a lot of work ahead of us, the government, local officials, and we the citizens, to look out for our own self-interest.
Are there any questions for the speakers in general, Dr. Nabat?
There are the question is about the available vaccines and do they work, and or should we wait I think we have addressed that one. Another version of that is the guacamole analogy of whether or not this vaccine, the current available ones, are the ones to use, or will they be ineffective? And then there was another question, which I don't think we actually addressed, was if in fact it turns out that in, let's say, August, or maybe even sooner than that, let's say July, a strain evolves that in fact neither Moderna nor Pfizer or any of the available vaccines at that point in time are effective against that strain. Should we still take the available vaccines or not? And I throw that out to Dr. Despani, Dr. Nars.
I'm of the opinion that you would still want to get vaccinated because there won't be a vaccine. I'm sorry, there won't be a virus that like completely abolishes, like 100%. I mean, the time that would take to happen would entail that there are like a myriad of other point mutations, like again, like that cluster. I mean, I still think that it's worthwhile to get the vaccine. And then again, just similar to the influenza virus vaccine that we get seasonally, I think that might be a modality moving forward for the vaccine makers to kind of roll one out, every year and whatnot. I think the reason why I'm not worried about whether the vaccine makers can do this or not is because, and like I always say this, I believe it was on mid-January 2020, whenever the first viral sequence for SARS coronavirus 2 was first published. And within 48 hours, there was already a vaccine candidate ready. And then what took it so long to actually receive the emergency use authorization is the fact that it had to actually be tested in animals, humans, et cetera, through phase 1, 2, 3, right? So you can really generate a new, like vaccine candidate very rapidly, right? Because what is empowering about the messenger RNA technology is that it's a platform, meaning that all you do is just, swap out the genetic material for the like coding for the viral spike protein, and then you can play. So, right, plug and play, right? So that's what's really cool. And I do also want to point out that I was asked by one of the audience members, what should I be focused on with the new Los Angeles, I guess, variant? And right now, the fear is that there's 1 point mutation within this Los Angeles variant called L452R, that's leucine gets changed at the 452nd point in the viral genome into arginine. Leucine should be neutral, I believe. And then the arginine is positively charged. So it's like a lot of, biophysical interactions going on. And unfortunately, that's actually in the receptor binding domain of that spike protein as well. So really, we're seeing evolution evolve the virus so that it actually wants to bind tighter. It's saying like, oh man, I don't know if I'm ever going to be able to get in. So like first chance, I want to bind as tightly to this host as possible. And then one downstream effect of that could be that it might require less virions or virus particles to actually get you infected. Because remember, in an earlier program, I mentioned that there's scientific literature has basically said that it takes 1,000 virions to infect you. Again, that might change if you have like these very tight binding variants. And that's actually the case with this California cluster. And that actually we don't know yet, but that could be one underlying reason as to why things have been going so haywire with the outbreak in California. So yeah, it's almost like it's one virus, but it's almost like you're fighting subtypes within it. So it's very, very difficult.
Let me ask a question, Dr. Norris and Dr. Archie and Dr. Despani. we had a task force that did review data reviewed by the NMA. I'm impressed that all of the UC schools are involved in the effort to eradicate this virus and bring our communities to get rid of the hesitance from taking it. We've heard talk about pregnant women being appropriately protected. Starting with Dr. Norris, what can help us get this community together to protect ourselves? Because unless a certain number of us are protected, we're all at higher risk. Uh, what are we going to do about that, Dr. Norris? How are you going to fix this problem? Is he unmuted?
Okay, now I'm muted.
Okay.
So very challenging problem, as we heard Dr. Williams mention in the beginning. So I think, first thing we have to do is make sure that we meet people where they are and that we respect and recognize that there's a reason to be apprehensive and reticent about taking the vaccine, right? And there's lots of reasons why people may have. So I think that's the first thing. Then I think, as Dr. Williams said, what my view is from there is after that, then is sort of providing people that balance between what the risks are of the vaccine versus the risks of getting COVID. And the scale is way off, right? So there's, I think 20, maybe 20 for Moderna vaccine after 4 million doses have been, 4 million vaccinations have occurred. There are 20 severe reactions with anaphylactic needing EpiPen, 5 hospitalizations. And then as Dr. Williams mentioned, there's 1 or 2 cases that are being investigated as to whether or not there's any associated deaths. For 4 million COVID cases, equivalent in the United States, based on numbers we see for infections and deaths and hospitalizations, for 4 million COVID cases, there are about 70,000 deaths and maybe 200, 300,000 hospitalizations. So you have 70,000 deaths and 200, 300,000 hospitalizations versus 5 hospitalizations and, possible, investigations to whether or not there's a death. So I think the weight is what we have to talk about. And then the other thing is we have to talk about, as was mentioned, our communities are being impacted disproportionately, and we want to make sure we're keeping people as healthy as possible. And for people who have mistrust, and there's both historic and contemporary mistreatment that leads to mistrust. I got that. What I need is for people to take the vaccine today so they can help us fight mistrust tomorrow, right? So we need people alive today to fight mistrust tomorrow. So it's just sort of echoing what we've heard earlier from Dr. Williams, Dr. Walk, and I think we just have to keep getting that message out there and getting it out there and getting it out there. And for the people, and then there are other people that have a whole variety of reasons, from misinformation on things that they see in social media from a variety of different places. And I understand people have different beliefs. I have different beliefs. My message is COVID doesn't care what any of us believe, right? And so we want to be thinking about taking the vaccine to protect us, because it's a deadly virus or causes significant illness, and particularly in communities of color.
Thank you. I'm impressed by the numbers that you mentioned, just the weight, the numbers of severe reactions and deaths that are documented occurring because of the vaccine versus the numbers that have been documented of deaths that occurred from COVID itself. I like the word that Dr. Williams used called motherhood. I get emails every day from a plethora, or rather a small group of even professionals and physicians about every time a person has one side effect. But I like to remind them that there are side effects to taking the baby aspirin.
Right.
The side effects to breathing if you're in the West Coast in LA versus the high percentage of potential death, not only if you're pregnant, but if you're Black from COVID. So we are trying to educate people. We don't want to twist anybody's tail, but we're trying to provide credible information.
And
When-
Rand,
yes,
I just add one thing, and when I do usually, so when I give talks to different community groups and et cetera, let's say the talk's an hour or so, I say, while we've had this webinar or talk and discussing potential side effects of a vaccine, another 150 Americans have died. Okay.
and more than 3% of those or more happen to be people who look like us. We've got a program coming up next week. I just want to speak briefly about it. First of all, let me thank Dr. Zaspani for producing the outstanding program today of inviting Dr. Archie, who has been my pleasure meeting and working with, and Dr. Norris to meet him again. He's got to take me out for a crab dinner as soon as next week, we're having an outstanding program. Dr. Williams will be the producer of that program, and he has obtained the former U.S. Secretary of Health, Dr. Louis Sullivan, will be with us next Sunday, and Dr. Augustus White and Dr. Richard Williams, and they will present a panel next week on the 31st. And also because of the high caliber of physicians that we have on our medical advisory, Dr. Neighbor, would you talk about the program that you have arranged for our Wednesday meeting?
For our medical advisory meeting, we are going to have a conversation that I wanted to have based on a question that was in the chat a couple of weeks ago. And the question was, what are reliable sources of information regarding the vaccines? And we're going to have Dr. Sonia Hutchins, who is formerly part of CDC, but who is now at Morehouse School of Medicine, to talk about sources of information and the reliability of sources of information. So I'm looking forward to that discussion.
Thank you. And lastly, I'd like to say, for those of you who may not have your own physician or may not have a health provider, to ask the question, do you need to take, do you want to take the vaccine? We are providing a service temporarily through Biometrics Second Opinion Expert. And the website is biometrics.secondopinionexpert with no s.com. And we will arrange for a credible physician to help you work through any questions you have about that. As you know, on this particular program, we cannot give out general information. And for the next month, this service will be free for those Black Health Trust people who want to call and discuss advice. But I urge you not to wait to ask questions, to get advice. And I thank you. We'll look for you again next week. I'd like to thank our distinguished speakers, Dr. Zaspani. We appreciate you putting this together. Dr. Carol Archie, it's been great listening to you, give advice to young mothers. And Dr. Norris, of course, as always, you've been outstanding. We're at about 11 minutes after the hour. Against the objections of one of my co-moderators, I want everybody just to say goodbye, and you got 60 seconds just to give a last word. Dr. Archie?
Thank you so much for having me. It's been a very enlightening and powerful experience. So thank you very much. I'm glad I was here.
Dr. Norris?
Oh, yeah. Thank you for allowing me to participate, and it's always great to come and learn, and look forward to coming back soon.
Dr. Despani?
Yeah, I just want to emphasize once again that in keeping with the adage that knowledge is power, the goal really is to keep you guys abreast and informed of everything that's going on with this pandemic. I know it's crazy. We thought that this would be behind us, but the reality is that just as we're evolving means of fending off the virus is evolving to stay one step ahead of us. So, you know, this is going to be a ongoing, battle, but I know that we can win this together.
Dr. Ivan Walks and Dr. Barbara Stevens, you have the final word.
Hi, you asked, Dr. Maxey, you asked Dr. Norris a question about how was he going to fix this? And the part of his answer I really love just speaks to, first of all, hey, Keith, good to see you again, to what Dr. Allen said. Dr. Norris said when he goes out to talk to people, we need to get out and talk to people. We need to get out and do these webinars, volunteer our time, encourage the community to get vaccinated. And I really appreciate that part of what Dr. Norris said more than anything else. We can talk to each other and we can make each other smarter. And Dr. Despani makes me smarter. Every time he unmutes, I feel smarter.
Me too.
But I think it's really critical that we take this message out to the community and encourage people to get their vaccine as soon as they can. If you're walking through Safeway and they say, we got some extra doses, raise your hand and get it.
Here's the test. Where's that glutamic acid modification he talked about?
Exactly.
All right, Dr. Maple Stevens?
Well, I'll wrap things up by saying that, and tag on to what Dr. Walk just said, but everyone that's on this call today or who is on the social media platforms, please spread the word about our webinar each week. Like us on your media platforms, forward the email to your friends when the flyer comes out, and copy us so that we can include these new emails on the invite for the Zoom. We need your help to get the word out so that we can get more and more of the community plugged in to what we are trying to share each week.
Well, thank you so much. Is Ms. Brenda Lee Agron?
Oh, wow, today's been incredible. Thank you to all the doctors. I must say, sometimes I feel a little overwhelmed, but it's nice to get this information. When I was a little girl, at 5 or 6 years old, I had several of my friends had polio, and we lived down in a rural area. But the doctors came and lined us little black children up and down the road to give us the vaccine, and we wiped out polio. And so I'm ready to take the vaccine. I don't care where they shoot me. They can shoot me in my ear, in my face, in my arm, but I'm taking it. But I want to leave you just with a little bit of encouragement. It says, hold on just a little while longer. Hold on just a little while longer. Hold on just a little while longer. Everything's gonna be all right. It's one power and one presence in the this universe, and it made all of us, and it made these beautiful doctors, and it works through them to heal all of us. So with the mastery teachings of the Christ within us all, we are therefore walking through a valley, not to stay, but to walk through it. And with the love and the light of God, I say, and so it is. I thank you all. Thank you, thank you, thank you. God bless us all. See you next week. I know I was hurrying up because I thought we'd be cut off anymore.
Amen. Thank you, Brenda.
Have a good day, everybody.
Bye.
See you next week.